This is Dr. Mark Thibert, plastic surgeon at Thunder Bay Regional Health Sciences Centre in the Northern Ontario School of Medicine. I'm bringing you our first podcast today. It is an educational podcast that is going to be dealing with the emergency management of fingertip injuries. I am quite pleased to have with me today Dr. Cody McMillan, a soon-to-be certified emergency medicine specialist who has been training also at the Northern Ontario School of Medicine. Following our discussion, I'll have a summary of all the points. I hope you enjoy. Follow us because this is going to be an ongoing educational series that is intended for medical education for the learners, as well as a source of education and information for my patients. Thank you very much. Enjoy our podcast. Today, I have with me Dr. Cody McMillan. He's a soon-to-be certified specialist in emergency medicine, training currently at the Northern Ontario School of Medicine, and we're very pleased today to have Cody do a little presentation for us on the emergency management of fingertip injuries.
Perfect. Thank you for having me. They're super common injuries, things that we see in Emerge a lot, and you guys get referred a lot.
The fellows in the emergency department see an awful lot of these, very, very common, and so this is a very good first place to start for our educational podcast.
Someone comes in, they cut part of their fingertip off. Can we put it back on? Some of the situations where you might want to be talking with a hand surgeon to talk about the possibility of getting re-implantation surgery would be injuries to children. They tend to be healthier, have better outcomes. If you do put a graft on, it's more likely to survive. A second being injuries to the thumb. The next most important finger would be the index finger, so very important to function. So you might have a bit of a lower threshold to try reimplanting if you have an injury to the tip of the thumb or index finger. Multiple digit amputation. And then the last thing would be a single digit amputation that is in a certain locations.
Certainly how injuries are managed is very largely dependent upon age, the underlying medical condition of the patient, other factors as to whether or not they're smoking or not, how the injury actually occurred under clean or dirty, contaminated conditions.
So if we're going into situations where you might be less likely to try and put a partially amputated finger back on, so crush type injuries or avulsion type injuries, in those scenarios you're going to have damage to other structures too, so it's not going to be just a clean cut. You're going to have crushing or other injuries to the nerves, more importantly the blood vessels, that are going to make it a lot less likely that that piece is going to survive if you put it back on. If you have multiple levels of injury, so somebody gets their hand sort of put in a snowblower or something like that, and you've got injuries sort of all throughout the finger, again, lots of damage throughout the finger, so less likely that if you go to put that back on, you're going to have good outcomes. Relatively contraindicated in people with really significant smoking disease, vascular disease, type 2 diabetes, or uncontrolled type 1 diabetes. So again, all these things that sort of lead to peripheral vascular disease or vascular disease in general, that's going to make it less likely that you're going to have good outcomes. If the digit has been cut off for more than 24 hours, again, a lot of damage to that tissue, not getting oxygen, less likely to have good outcomes.
You can successfully reimplant a finger up to 24 hours if all the other conditions are met. The other question I often get asked is some of the pieces of tissues that get pinched off at the tip of the finger, and the question being, should I sew it back on as a full thickness graft? And almost none of those under traumatic conditions really survive. I would prefer just to dress the wound to make sure that the conditions are favorable. Usually 4 or 5 days or so later, I'll go in and do a full thickness graft and have a virtually 100% success rate.
In zone 2 of the hand, on the flexor surface, in sort of Camper's chiasm. The reason for that is there's a common tendon sheath between the superficialis and profundus. So if you're sort of cutting the tendon in that area, if you reattach it and have healing there, you're going to get all these adhesions in the tendon sheath.
When the two tendons are so close together, tendons, as you go towards the baby finger side of the hand, get progressively smaller and smaller, so that an injury, for instance, a similar injury to the small finger, where the tendons are almost basically the sizes of threads, if you add scar tissue on top of that, you're almost never going to get a good outcome. Wow. Flexor zone 2 amputation has virtually little chance for successful functional outcome. Different considerations, right? So
Yeah.
on your thumb, index, and middle fingers, those digits are predominantly used for oppositional function, for picking up things, doing fine activities, so even something simple as buttoning up the buttons on your shirt. When you go towards the ulnar side, so the baby finger side, those digits are more important for your overall grip strength of your hands. The other point that we didn't touch on is the importance of using time for any of these very severely traumatized tissues. There's almost no advantage to racing and breeding and throwing away some of this tissue because you never know whether it's going to survive.
So I got a figure in front of me. The first one is going to be line A, and that's just going to be a injury to the fingertip where you're just cutting through the skin, soft tissue, and pulp tissue. There's no bone exposed. You haven't gotten it to any tendon zones. It's just all soft tissue. In those types of injuries, less is more. The goals are going to be to maintain length, make sure that you approach as normal sensation and function as possible. And then the last sort of consideration is just trying to make it look a little bit better. In these types of injuries, what they recommend is if there's less than a centimeter taken off, not much nail bed involvement, no exposed bone, just serial dressing changes like you mentioned. If there's tissue there that's a little bit chewed up, like you mentioned, sort of leave it alone and see sort of what's viable. Do the daily dressing changes. So if you're seeing tissue that's sort of starting to die there, you can start to debride it at that time.
Cody, yesterday we talked about what would be my suggested best method for cleaning up these tissues in the emergency department. Want to describe that for me?
Yeah, absolutely. So with all of these, like Dr. Thibert has mentioned, we want to reduce the bacterial load, reduce the likelihood that this is going to become infected. The first step to that is going to be doing a good digital block. So that's definitely something I'm going to start using going forward.
Yeah, that's been very effective, Cody, for me throughout the years. By using this, I've not had any wounds that have gotten infected.
Got the area clean now. We know we're going to dress it. What kind of dressing to use? So we talked about this a little bit. You want something that's going to be non-adhesive. You don't want it to be painful when they have to take it off, especially if they're getting daily dressing changes.
Right.
So I imagine something like an Adaptic or something would work.
The one thing to avoid are products that will help to stop bleeding, because a day or two later when they come to see me, it's extremely difficult to get that off a couple of days later.
So you alluded to this a little bit before. My understanding is what I would do is I would take that piece and I would sort of debride any kind of necrotic tissue from it, take down the fat, and then just plop that back on and put some sutures in. And after that, we not look at it, don't touch it, leave it alone.
Usually if you're going to put that tissue on as a full thickness graft, the magic number is about 5 days afterwards that I'll take that first bolster dressing that's putting pressure. So at 5 days, I'll snip all those little tails that you were talking about, take the bolster off.
Okay.
And I think you're going to tell us about that right now.
Yeah,
Good timing.
So moving back to that figure, if we go to the next couple of lines, so line B and line C, so both of those are kind of injuries where someone like myself would want to get a hand surgeon involved. So
Yeah.
Line B being a volar oblique line, and line D being just a transverse straight up and down cut. So in those situations, from the figure, you've got bone poking out.
Yep.
So there's bone involvement, and you have less tissue to sort of create some soft tissue coverage. In order to cover that, you might have to clip some bone back. And with our goals being to maintain length, we want to introduce someone like yourself who might be able to do something like those skin flaps to be able to cover it without trimming back too much bone. But we were talking the other day about one type of flap that's commonly used, which is the V2Y.
So once you've made that V cut on the palmar surface of the fingertip, you have to mobilize that tissue a little bit so it'll slide forwards over the fingertip. And once you've just freed that up, then that tissue should readily move forward, and then you can reattach it to the tip of the digit. The advantage of that technique over skin graft is that you maintain the padding and you also maintain the sensitivity of the fingertip. A couple of caveats that I have to insert here. If you're in the emergency department and you have any of these injuries and you are not comfortable with dealing with it, the easiest thing to do is to say, Dr. Thibert, I need your help, and ask me to come in and have a look at it. The other thing that we mentioned earlier is that there's almost no advantage to making a rash decision initially about what tissues will and will not survive, because when they've been crushed and traumatized to that extent, the vascularity goes into a little bit of a shock, and you can't tell right off the bat what's going to survive. And the last thing you want to do is to make a rash decision early on that's going to sacrifice tissue that might survive later on. So a period of observation is always very, very beneficial. I think we've covered everything, Cody. Thank you very much for your excellent presentation. I look forward to further opportunities to provide educational insights. So thank you very much for your hard work on this. Look forward to our next presentation on the educational series. Have a great weekend. Brings an end to our first podcast in the educational series dealing with plastic surgery issues here in Thunder Bay. We are grateful to have had Dr. Cody McMillan with us in the studio today talking about fingertip injuries. The salient points that came out of this were the management of fingertip amputations and indications for reimplantation, as well as the assortment of methods that are available for the salvage and reconstruction of various fingertip injuries. What became patently obvious in this discussion was the fact that most traumatic injuries require a period of observation if you are in fact going to salvage tissues and length of the digit, which ultimately translates into the function of the finger and the hand. This was all very well presented by Cody, who I'm grateful again for his participation. Please log in again and pass this along to your friends. Share, like, and join my channel. Subscribe. We'll be bringing you further educational episodes. Hope you have a great weekend. Stay safe. Stay tuned. Thanks again. This is Dr. Mark Thibert signing out for another great session on plastic surgery management issues. Bye now.